Good afternoon, everyone. Beth, thank you so much for inviting me. Thanks to Tom, to Dr. Kinney, Dr. Sharma. So a quick little survey from the audience. How many of you know what the indications are for cardiac rehab? And don't be shy. Raise your hands. All right, we're off to a good start then. So we're going to be discussing a lot of these things today. And how many of you feel comfortable referring a patient to cardiac rehab? Show of hands. Okay, a little better. All right, we're getting there. Okay, so my agenda today, we're going to be discussing how, COVID impacted everything, which we know that it did. We're going to be returning to Cardiac Rehab University. We're going to be attending a course in 101 about what cardiac rehab is. We're going to be learning about what the barriers to cardiac rehab are, which is the point of our presentation today, and how we can sustain referral and enrollment. And then we're going to be talking about sustaining cardiac rehab and, of course, our key takeaways. So, COVID. We have to talk about it. We know that it decimated the entire healthcare system. We know that it made it increasingly difficult and the cascade effects that it did have on both practitioners, on our patients, but of course on the healthcare system as a whole. That trickle-down effect really reactivated and activated cardiac disease sequelae, and it resulted in admissions and readmissions. And what did that subsequently do in a lot of cases? Of course, it reactivated a lot of mortality. It made our patients with cardiovascular disease sicker. So what it did, it caused a lot of strain on our existing cardiac rehab programs. There was a lack of enrollment, a lack of referral. That strain kind of continued, and what happened was more than 220 cardiac rehab facilities closed. So let's go back to Cardiac Rehab 101, all right? It's a Class 1A medically recommended guideline, lots of rigorous research behind it. Our friends at the Joint Commission, it's a core measure. So what does this program really consist of? This is a customized program looking at a patient with specific cardiac disease and diagnoses, and what it focuses on a baseline physical assessment that's either done by yours truly, or we have a wonderful cardiac nurse that works with us, for a multi-system assessment, and then it goes into the exercise science end of things. It consists of 2 sessions a week, 1 hour for each of those sessions, total of 18 to 36 sessions, can range. And what really the core focus of this program is looking at the patient's hemodynamic response to activity. They're telemetry monitored. If they have diabetes, we do point of care testing with finger sticks at bedside. I say bedside because I'm a former bedside PT, so that's always ingrained in my head. But it also relates to secondary prevention and ongoing education. What do we do as nurses, as PTs, as techs? We provide education. And that really is the crux of what cardiac rehab is. And also standing here today is educating each other on what cardiac rehab is. As I mentioned, there's that baseline physical assessment, physical activity and progression. And as Beth was talking about earlier, we talk about teaming. We talk about working with our cohorts in a dynamic environment. And that's really what this is. And when you look at the level of specialists that we have involved, we have an amazing group of cardiologists. We have an even more amazing group of exercise physiologists and nurses. You got a physical therapist. You have care coordination team, and you have a registered dietitian. So it's a really fantastic cohort that involves not just physical activity, hemodynamics, but also secondary prevention. So what are those indicated diagnoses? And I listed over here actually the most common diagnoses that we see. We see our friends, the PCI, the CABG, the valve replacements, stable angina, STEMIs or NSTEMIs, HFrEF, EF less than 35%, our transplanted patients, and very excitingly, we actually started to see our LVAD implants here, and we also see peripheral arterial disease. So a host of indicated diagnoses and disease parameters that we see, and there's a lot more. So what are the 10 tenets of cardiac rehab? And it really focuses on these core components related to secondary prevention and education. So it begins with our patient assessment. It goes into nutrition counseling, exercise training, physical activity counseling, weight management, psychosocial management, blood pressure management, lipid management, diabetes management, and tobacco cessation. I have to remind myself of these a lot of times. I have to look down and I literally have to remind myself and our team that these are all the things that we do, and these are quite fantastic. So let's get to the barriers. Let's get to the good stuff. We're going to talk about what we kind of explored in our very first survey over here. What is the biggest barrier? The lack of recommendation by the primary provider. So it really begins with that referral. It begins with that knowledge about the referral. But how does that dovetail into that? It's the clinician knowledge about cardiac rehab. It's to know what those indicated diagnoses are. Then it's the actual referral and the placement of that referral. There's lots of other things that impact that. It's geographical access. It's been shown that 45% of patients are less likely to attend cardiac rehab if they live an hour outside of a metro area. It's an insane statistic when you think about it. Use of advanced technologies. For those same patients that are geographically inaccessible to cardiac rehab, what about options like virtual rehab? We're using all the telehealth parameters right now. Why don't we apply them here? Well, we do have that. We will talk about that shortly. Lastly, of course, the epidemiological factors, the ethnocentric factors that cannot be understated. Low engagement of diversity, access for complex cardiovascular diagnoses. And as I was really excitedly talking about our VAD program, that is really what is also a core focus of our complex cardiovascular disease patterns. Some statistics for all my nurses out there. Only 2 out of 3 nurses know the phases of cardiac rehab and the activities related to each phase. More than 60% of nurses were unaware of their roles and responsibilities in referring to cardiac rehab. Then we get down to brass tacks here about each of the disease sequelae and a lot of the epidemiological factors. Only 10% of patients with heart failure are referred to cardiac rehab. Less than 3% attend 1 session. Minority status is a predictor of low referral and lower attendance. And again, there's that outside of the metro area. There's a tremendous need for this vital resource, and we are all the key. So an interesting statistic that I like to always highlight, only 19 to 34% nationwide attendance. The target is 70%. But I will happily say with all of the measures that we've implemented here at Mount Sinai Fuster Heart, we have about an average weekly attendance of 78%. And we're going to talk about some of those. We actually, I pulled up the statistics just anecdotally, and I looked at last May, and we had a total of 660 visits this last year when we first kind of settled up, and this year it's 1,022. So this works. The system that we have works, and it can be applied to other facilities across the board. It's just a question of getting the hierarchy in place and involving all of our leadership who supports us unconditionally. So let's talk about how we're going to sustain cardiac rehab. So there's this wonderful team that you see here in a couple of the pictures. I wouldn't trust that guy in the red tie in the middle there. Definitely would not trust him. And you see him again in the purple shirt on the other side, so he's kind of sketchy. But what is this really about? Ongoing education. The thing that we all love to do as practitioners, we love to educate our patients. Let's educate each other. And we have to kind of revisit that cardiac rehab 101. We have to go back to the Cardiac Rehab University and understand what those, understand what those indications are. You really need to know these kinds of things here. Like what is the structure of cardiac rehab? What is the overall hierarchy of how does it work? What are the, let's hope I didn't, okay. What are the indicated diagnoses? What are the 10 tenets? What is the secondary prevention measures that are offered at cardiac rehab? So let's see if I can find my space again. All right, there we are. So getting back to that cardiac rehab one. What we've also instituted here is kind of like the cardiac rehab, I want to say, university or academy. You get to hang out with yours truly whenever you need help kind of referring or getting down that information about how to refer, how to enroll, what the indicated diagnosis. We have badge buddies, we have laminated cards, we have resources on EMR, we have slide decks. I met with Tom's team of primary providers a couple of times a month to kind of go over what the indications are, and that's why I'm here. That's why we have this wonderful cohort of care coordination team. We have our exercise physiologists. We have all of the resources that are available to make sure that our nurses, our primary providers, our technologists know that the resources are there and how to refer these patients. As you can see, there's my amazing team led by our medical director, Dr. Marianne McLaughlin. And it does take a village. I hate to use quote the vernacular here, but we have our care coordination team. We have our medical clearance team consisting of myself and our registered nurse. We have the leadership interface directly with Dr. Beth Oliver, with all levels of leadership here. And we have support from our fantastic certified diabetic educator, Marty Friedman, who is our nutritionist. So to reach into that kind of, how do we automate this process? How do we make this process easier for primary providers, for practitioners, about knowing how to do this? Well, we have an automated referral system. So within our database, within Epic, we really optimize the use. And that's kind of one of the core measures that is also looked at by the Million Hearts Initiative, is that this central referral and this automated referral process is necessary to get these patients enrolled in a reasonable frame time. And what we have here is within EMR, we have a qualifying diagnosis hard stop. Once those orders are entered, if the patient fits the criteria, they have a PCI, let's say they have a functional capacity, they're cognitively intact, let's say we know that they didn't go to a rehab facility, send them on in. That passes through the hard stop, and then it goes through the various indications, or if they're contraindicated or if they're not indicated. It goes to a central database. Myself or a cardiac nurse reviews the patient's information, and then they go in for insurance verification and scheduling. Easy, right? Okay. How do we sustain attendance and adherence? Well, geographical access. We have a wonderful partnership with Mount Sinai and Nassau now, which is great. So for our patients that live in Queens or live in Long Island, it's really fantastic. They have access to this geographical location now. We know how difficult it is for patients to get to cardiac rehab. There is really a paucity of locations within the New York metro area. So we have that great access with our partnership, with our partnering team. Let's utilize advanced technology, right? Everybody's doing telehealth visits right nowadays. Why aren't we doing the same thing? We are. Actually, this summer, what we're starting to do is we're starting to roll out our virtual cardiac rehab program, and it is a hybridized program where it consists of synchronous and asynchronous visits. So the patient will exercise with yours truly, let's say, but then they will exercise on their own. They will come in for visits to also be checked up on to make sure that their hemodynamic response is appropriate. We'll monitor them on telemetry, but then we'll let them stratify and go home and see how they're due on their own. So 93% with virtual rehab, and a couple of studies revealed that they attend one or more sessions. That's okay, but 75% attend the virtual sessions throughout the entire course of their cardiac rehab. So it works. And this is actually the risk stratification that we developed here at Mount Sinai Fuster Heart to stratify these patients. If they're low, moderate risk, they can use this hybridized model. They can come in for their initial assessment, be checked out for a couple of sessions, make sure that they're hemodynamically stable. I make sure that they're not a tremendous fall risk and they're using their DME appropriately, but they're probably not. And then we go to modified kind of hybrid where they can do in-person. They're a little bit higher risk, and then high risk where they need to be center-based. And based upon each of these risk stratifications, it's determined on how many sessions they can attend feasibly. The last thing, attendance and adherence, diversity, equity, inclusion. One of the most important aspects for our patients. If you build it, they will come. And honestly, I am very pleased to announce too is that our program really has a very diverse program of patients from all different types of walks of life. We also have our complex cardiovascular cases as such with our VAD program, and we also supply language assistant technology. We use that, our virtual, we call her Sally, but she's kind of the rover that goes around. We have two of them. And if we have Spanish-speaking patients, if we have French-speaking patients, if we have Russian-speaking patients, we have the ability to be able to interface with them directly. So this was a great joy for us. We got to treat this patient that had spontaneous coronary artery dissection. And at the bottom, we were featured on Channel 2 News, and as you can see at the bottom there, it says lottery. Unfortunately, we didn't win the lottery that night, but we did win the lottery with this patient, and we really consistently win the lottery with our patients. I really thank you guys so much, and really the key takeaways before I finish, refer, 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 and then really understanding Cardiac Rehab 101. Thank you so much, everyone.